Here it is. Here it is. I grabbed the image real quick from Google Images. I always remember this umbrella for some reason. However, I don't know why they put this umbrella there, but I always remember this umbrella, the shape. This Carney complex is actually a hereditary complex, which the patient suffered from some kind of skin pigmentations and some kind of myxomas and some overactivity in some of his endocrine glands, the adrenal glands, the thyroid glands. So they might have hyperthyroidism. They might have hypersecretion of cortisone, Cushing, or anything. And here we go. You have the reproductive organ tumors. This is the sclerosing Sertoli cell tumor is one of the entities which exist nearly exclusively in this Carney complex. And tumor affecting some nerves and bones and other tumors. So this umbrella make me for some reason remember the Carney complex, but this is the Carney complex association with this calcifying Sertoli cell tumor. You can also remember it from the CA, calcifying Sertoli cell tumor, Carney complex. Here it is. So you can remember it from the CA and the CA. There's also the protein kinase AR1A mutation. It's frequently associated with that one, but it's commonly asked the Carney complex. This was the question that was asking board vitals, as I remember. Rare tumor, the other tumors, you remember that gonadoblastoma. Gonadoblastoma, you might have some germ cells resembling these germ cell neoplasia in situ, which are these ones, with this halo around the nucleus and this large nucleus, which is kind of irregularly shaped nucleus. And aside from that, you might see some sex cord cells resembling immature granulosa cells seen there in the background. Some eosinophilic basement membrane, you might see it right there. Some calcification. Just the only thing that was asking gonadoblastoma in one of the Q banks, they didn't even include any histological picture or histological image. They asked that there was a baby or a kid who had an undescended testis. Cryptorchidism, there is undescended testis. And then they asked, well, if this condition is left untreated, this patient is at risk of testicular neoplasm, as we know. What kind of testicular neoplasm is common to develop on top of undescended testis? It's this gonadoblastoma thing. It develops in individuals with gonadal dysgenesis and undescended testis also. But gonadal dysgenesis is even more common. I believe undescended testis is more commonly associated with seminoma. That's what I remember. Yeah. It's more associated with seminoma. Gonadal dysgenesis is happening in something like a Turner syndrome. There is a Turner syndrome patient having this gonadal dysgenesis with this streak ovaries, or let's say you have a male with Klinefelter. Turner syndrome is more common in females, though. But I'm telling you what I mean. What's meant by gonadal dysgenesis it's not really Turner, but that's what's happening in Turner in terms of gonadal dysgenesis. There's also Klinefelter syndrome, which I think is more relevant here because we're dealing with male pathology, testis. So Klinefelter syndrome is a male with an extra X. He might have these gonadal dysgenesis thing. Well, you don't really have to dig deep into gonadoblastoma. This is the adenomatoid tumor, the paratesticular tumors. Remember that? The gland-like things. See, I told you it's coming from the peritoneum around the testis. Mesothelial tumor, actually. This is a benign mesothelial tumor present with paratesticular mass. It usually exists in the epididymis around the testis. See, gland-like microcystic spaces. These spaces are usually lined by cuboidal or flat cells. See these flat cells or some kind of high cuboidal cells. And there is these thread-like bridging strands Please remember these thread-like bridges. They're always there in the picture. You have also some kind of fibrous stroma with some lymphoid aggregates or some lymphocytic infiltration. I think this one, or maybe that one. Sometimes you might have some signet ring, but don't care about it. This is a mesothelial tumor, so it's positive for mesothelial markers. Mesothelial markers you need to remember, not only for adenomatoid tumor, but also for mesothelioma. It's very common to be asked as a cytology question of a patient who's getting like an aspirate from the pleura or a pleural fluid aspirate for cytology and having these malignant mesothelial cells, mesothelioma, and they're telling you these cells are positive for D240 calretinin. D240 calretinin are the two most common mesothelial markers. And for this, I will mention I'll mention one of my mentors in my program. Her name is Dr. Han. Dr. Han, always as a first-year resident, she always asked me about this D240 carotene, to the point that these were the first immunos that I knew by heart. Because she told me, well, Muhammad, I will keep asking you for D240 carotene. And she kept like going and going in the lecture. And every time we get to a mesothelial neoplasm, she told me, Muhammad, what's the key immuno? D240 carotene, Dr. Han. D240 carotene. Until I became like specialized in these like to IHC, I became well known with my colleagues. Oh, Mohammed, D240 carotene, just don't forget. Okay, so these mesothelial markers, these are the two key immunohistochemical stains that you do for mesothelium, D240 carotene, WT1 also. Since this is a mesothelial neoplasm, so it's usually positive for mesothelial markers or IHC markers. Adenomatoid tumor, remember the threads, please. It was asked in one of the questions as a diagnosis, paratesticular neoplasm or paratesticular mass. Please remember. Mesothelioma, it's very rare to happen in the testis, usually happen in the pleura. Malignant proliferation of mesothelial cells. You might have variable appearance, but often you get it at the epithelioid variant in the testis. These epithelioid cells, please remember, and it completely usually envelop the testis and invading the testicular tissue itself. It's also positive for mesothelial markers. Remember, D240 carotene WT1. It's less associated with asbestosis, unlike the malignant mesothelioma of the lung, which is highly associated with asbestosis. When we get there, we'll know that. Adipocytic tumor, all the types of adipocytic tumor. However, I didn't highlight anything because we will discuss the adipocytic tumors in full detail in the soft tissue part. The adipocytic tumor, any kind, can happen in the testis, like the benign lipoma, the well-differentiated liposarc, the atypical lipomatous tumor. Any of these might happen in the testis since you're having some fatty tissue in the around the spermatic cord, so you might get any of the adipocytic tumors there. There's also some smooth muscle tumors that might happen from the smooth muscles that are there in the spermatic cord and surrounding the testis as well, like this like cremasteric muscle and the muscle cells. So the muscle cells, you might get leiomyoma, leiomyosarc, but these we'll also discuss in details when we get to the leiomyoma, leiomyosarc. Rhabdomyoma, rhabdomyosarcoma. I told you that you might have testicular rhabdomyosarcoma. It was asked in one of the Q banks, and the classic feature is you have these muscle cells, rhabdomyoblasts, with cytoplasmic striations. Please remember the cytoplasmic striations. Here is eosinophilic rhabdomyoblasts with abundant eccentric cytoplasm and striations. It's usually positive for muscle markers, which are myo, which is myo, D1, and myogenin, myo are the muscle marker. This is myo, muscle, rhabdomyosarcoma. There is a spindle cell variant of rhabdomyosarcoma, but it's usually not very common. Here is how it looks. It's actually very confusing. This is embryonal rhabdomyosarcoma with spindle cells, but they usually show these classic rhabdomyoblasts to give you a hint that you are dealing with a rhabdomyosarcoma. Usually that's the case. I don't want you to like confuse yourself by these rare entities, rather than focusing on the common entities, GCNIS, seminoma, embryonal, yolk sac tumor, choriocarcinoma. These things you need to clearly remember before taking the next step and trying to do your best in these rare variants or rare entities, like calcifying variant of Sertoli cell tumor, Carney complex, or like the rhabdomyosarcoma, spindle cell variant of embryonal rhabdomyosarcoma, testicular mesothelioma. These things are okay. Gonadoblastoma. These things are like relatively rare entities, so you need to digest the important entities first before doing your best in these rare entities. That's it for the testicular tumors. I hope that you enjoyed this whole lecture going over the different types and flavors of testicular neoplasms. And we will have a virtual microscopy session for the whole GU after I'm done with the testicular neoplasms, prostate pathology, renal, including medical kidney and renal tumors. We will have a virtual microscopy session covering the whole 4 entities. It's going to be good because I will go over the common entities in each, but it's going to be a refresher. Also, I'm waiting for the feedback of everyone. I know it will take some time for the videos to be watched by a lot of my colleagues, but I'm happy to take your feedback in the comments section for the videos, and enjoy your day. As always, thank you very much. Shukran jazilan.